Hi doctors, in this video we are going to discuss pharmacology. The first question, which of the following amphotericin B formulation is least likely to cause infusion related reactions? Options are A, B, C, D. There is amphotericin B colloid dispersion, amphotericin B lipid complex, liposomal amphotericin B, and amphotericin B deoxycholate. This is called conventional amphotericin B. Here the question is, which of the following amphotericin formulation is least likely to cause infusion related reaction? See, all the amphotericin B formulation normally given as IV infusion. When they give intravenous infusion, definitely they have risk of causing fever, chills, rigor, or infusion related reaction. Here question, which is least likely causing this problem? The answer is option number C, liposomal amphotericin B. See, when you see the comparison of infusion reactions of various amphotericin B preparation, what Goodman-Gilman book says, among this, amphotericin B colloid dispersion has more chances of causing infusion reaction, followed by conventional, that is amphotericin B deoxycholate. Conventional, C means conventional amphotericin B. Next is amphotericin B lipid complex. And among this, least reaction with the liposomal amphotericin B. This is one important statement given from Goodman-Gilman, so that this question is framed. Here, another interesting question, what is the major difference between the new formulation and comparison with the conventional one? I go one by one. Most of the common adverse effect of amphotericin B will be, they are given as IV infusion, so causing infusion related reaction, which is more with, as I told earlier, amphotericin B colloid dispersion, and least with the liposomal amphotericin B. Anyway, the first point, amphotericin B may cause fever, chills, rigor during infusion. It is called infusion related reaction, also called shake and bake syndrome. This reaction can be minimized by prior injection of steroid like hydrocortisone, or giving paracetamol or ibuprofen NSAID to control the fever, chills, or can start some antihistamines also. Like that, this can be prevented. Okay. And next question, amphotericin B means one of the most important adverse effects, dose-limiting toxicity, nephrotoxicity. This is maximum with the conventional amphotericin B. Liposomal amphotericin B and other ABCD, ABLC, they also have less chance of causing nephrotoxicity. So one important difference, conventional amphotericin B have more chances of causing nephrotoxicity. Here, there is something called electrolyte imbalance. What are the electrolyte imbalance? The same in amphotericin B toxicity. They may have hypokalemia, also hypomagnesemia. This nephrotoxicity is the dose-limiting toxicity. This can be minimized by maintaining adequate hydration. That is, prior to conventional amphotericin B injection, you should give 1 liter normal saline. So maintain adequate hydration to minimize nephrotoxicity. Or also go for the liposomal amphotericin B, it's a targeted drug delivery, less chance of nephrotoxicity, systemic problem like nephrotoxicity, but costly. Another important problem of amphotericin B, they cause the production of erythropoietin, thereby causing anemia. So this can be managed by supplementing the erythropoietin. And intrathecal administration of amphotericin B may cause CNS adverse effect like seizure. All these are common adverse effect of amphotericin B. Here, most important question, the dose limiting toxicity of amphotericin B, nephrotoxicity, that's most important. Next question. Which of the following antimicrobial agent not useful in meningitis? Options are isoniazid, fluconazole, cefazolin, pfloxacin. Here, simple, straight question, but little bit tricky question. Say isoniazid, a drug for TB, lipid soluble, easily crossing the blood-brain barrier. So this can be useful for tuberculosis meningitis, useful for treatment of meningitis. And fluconazole, an antifungal agent, useful for meningitis. Whereas cefazolin, come on, cefazolin actually first generation cephalosporin. Usually first generation cephalosporin having poor entry to CSF. They cannot able to cross the blood-brain barrier, so they cannot be useful for treatment of meningitis. So answer for this question option C. Whereas among the quinolone, P-floxin a wonderful capacity to cross the blood-brain barrier. So P-floxin can be useful for treatment of meningitis. Here extra questions are, look here. Fluconazole antifungal drug useful for treatment of two things. Useful for cryptococcal meningitis. See, actually for cryptococcal meningitis, the first line drug of choice will be combination of Amphotericin B plus 5-flucytosine. 5-flucytosine actually anti-metabolite acting on nucleus, inhibiting the nucleic acid synthesis. Amphotericin B acting on cell membrane. So when you give combination of amphotericin B with the 5-flucytosine, they are supra-addictive synergistic action. So that's a very good first line choice. Following this, maintenance therapy by using fluconazole. So fluconazole used as a maintenance therapy in case of cryptococcal meningitis. Of course, extra one point, fluconazole is the primary first line choice. So first line drug of choice for treatment of coccidoidal meningitis. So 2 point we should know. Fluconazole actually first line drug of choice for coccidoidal meningitis. That's 1 point. Second point, fluconazole can be a maintenance therapy in case of cryptococcal meningitis. Normally for cryptococcal meningitis, first line choice will be Amphotericin B plus 5-flucytosine. Okay. P-floxin among the quinolone having very good penetration power into CSF. And regarding cephalosporin, usually first generation and second generation do not attaining good concentration in the CSF. So normally for treatment of meningitis among the cephalosporin, third generation, fourth are very good, especially ceftriaxone, a wonderful third generation cephalosporin, a very good drug for treatment of meningitis. Okay, again 1 point. I told say first, second generation do not have that much entry. Here one extra point. Among the second generation, we have one drug called cefuroxime. Cefuroxime actually second generation cephalosporin, but that may able to have high amount of CSF concentration. So the one and only second generation drug able to attaining good concentration in the CSF mean think of cefuroxime. But in general, first generation, second generation not having that much role in meningitis. That's about this question. Coming to the third question, drug inhibiting 5-deiodinase and decreasing the T3 level include all of the following except. So super question. Actually, the T4 tetrahydrothyronin in the peripheral circulation converted into active hormone called T3 trihydrothyronin. This conversion done by help of 5-deiodinase enzyme. The question is, drugs inhibiting 5-deiodinase thereby decreasing level of T3 include all except. That means all of the following drugs are inhibiting peripheral conversion of T4 to T3 except like the question. So here options are amiodarone, propyl tyrosine, lithium, ipodine. Straight question. Answer is option number C, lithium. See, lithium causes hypothyroidism. Lithium causes adverse effect of hypothyroidism. That is because lithium inhibiting release of T3, T4 from the thyroid follicle, It is not inhibiting the peripheral conversion. It inhibiting release of T3, T4 from the follicle. So answer is option number C. Whereas amiodarone, propyl tyrosine and ipodate, they will able to inhibit peripheral conversion of T4, T3. So to explain this, look here. Normally, T4, that is tetraiodothyronine, can be converted into T3 by removal of one iodine. The removal done by one enzyme called 5-deiodinase enzyme. So what are all the drug inhibiting this enzyme, thereby inhibiting conversion of T4 to T3 includes we having beta blocker, the so-called propranolol, and then amiodarone, one of the class 3 anti-arrhythmic agent, then propylthiouracil, then steroid, dexamethasone, and hypodates. All these drugs will be inhibiting 5-deiodinase, thereby inhibiting conversion of T4 to T3. Okay, here extra one important question. Propranolol not only controlling the conversion of T4 T3, propranolol also able to control the symptoms of hyperthyroidism like tremor, palpitation. So propranolol having dual action, controlling the symptom as well as controlling active T3 formation in peripheral circulation. Next question, look here. This is another interesting point you should know. That is, there are some non-thyroid drugs causing adverse effect of hypothyroidism. I will explain this point. Imagine it is the follicle, thyroid follicle. Imagine it's the blood vessel. Here my first interesting question, look here. From in the follicle, T3, T4 hormone getting synthesized and stored. Okay. Now, there is one drug called lithium. Lithium, a drug useful for bipolar disorder, useful as a major therapy in bipolar. This drug may cause adverse effect hypothyroidism by what mechanism? In lithium inhibiting release of T3, T4 from the follicle. Thereby, lithium causes hypothyroidism. Another interesting question. In the circulation, T4 converted into T3, that can be blocked by, that's what I told in my previous slide, like anti-arrhythmic like amiodarone, propranolol can inhibit peripheral conversion. Here, one very interesting question. There are some anti-TB drug. Anti-TB drug causes hypothyroidism by inhibiting synthesis of T3, T4. The question for AIIMS exam, which are all the ATT, which are all the anti-TB drug causes hypothyroidism? Answer ethionamide and pass. Pass means para-aminosalicylate. Para-aminosalicylate. They will cause adverse effect of hypothyroidism. Among these, ethionamide is the most important drug causing maximally hypothyroidism. And finally, one more question. See, we have one drug called sodium nitroprusside. This we know useful for treatment of hypertensive emergency. Okay, here an interesting question. Sodium nitroprusside may cause adverse effect of hypothyroidism. How? That's the question. How sodium nitroprusside causes adverse effect of hypothyroidism? Look here. The sodium nitroprusside containing cyanide. It's a cyanide containing antihypertensive drug. This cyanide in the body converted into thiocyanate. Thiocyanate. This thiocyanate having the property of inhibiting uptake of iodine. Inhibits uptake of iodine. Because of inhibiting uptake of iodine, the drug going to ultimately inhibiting synthesis of T3, T4, thereby having the risk of causing hypothyroidism. So, sodium nitroprusside also having the risk of causing hypothyroidism. That point you should keep in mind. Next, regarding etidronates, find out the false and true statements regarding etidronate. First of all, when you study this question, immediately you should know etidronate. Any drug name ending with the dronate, for example, alendronate, residronate, zoledronate. That means they call bisphosphonate, bisphosphonates. Okay. With this in mind, now go through the option. Regarding bisphosphonate, find out the true and false statement. Option A, prevent hydroxyapatite dissolution. Yeah, All the bisphosphonate having the property of preventing hydroxyapatite dissolution, a true statement. And bisphosphonate affect both normal and abnormal wound resorption. Yeah, very important question. One of the special action of bisphosphonate inhibiting osteoclastic action, thereby preventing bone resorption. Thus, with a wonderful first line drug choice for preventing osteoporosis. So, this is also true statement. Excreted through liver? No, 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 no. Bisphosphonate undoubtedly totally cleared from kidney. So it's a false statement. Bisphosphonate undergo renal route of excretion. They are unsafe in kidney failure. So it's wrong statement. Causes adverse effect of hypercalcemia? No, false. Bisphosphonate useful for treatment of hypercalcemia, not adverse effect. False statement. So true, true, false, false. True, true, false, false. That means answer is option A. So regarding this question, I want to extra point. Look here. Bisphosphonate. First point you should know what is the important mechanism action. Bisphosphonate, the main mechanism action, they causes apoptosis of osteoclast. They cause programmed cell death of osteoclast. The osteoclast, the one causing bone resorption. So, the mechanism action of all bisphosphonate inhibiting osteoclastic action. By inhibiting osteoclastic action, preventing osteoclast maturation, thereby preventing osteoporosis. This is done by inhibiting G protein that involved in activation of osteoclast. And bisphosphonates are first line drug of choice for treatment of osteoporosis. So currently, either drug-induced osteoporosis or age-related osteoporosis. For osteoporosis, currently the first line choice to prevention is bisphosphonate. And also first line drug of choice for treatment of hypercalcemia, very good drug of choice for treatment of Paget disease. Extra point, bisphosphonate nowadays undergo trial, whether they have anti-tumor activity or not. They are trying this in case of CML. So they have anti-tumor activity also. Coming to adverse effect, the old first generation bisphosphonates are given orally, they may cause erosive esophagitis. Oral bisphosphonate causes erosive esophagitis. That's why when a patient taking oral bisphosphonate, advise them to take the drug in standing posture in empty stomach with a full glass of water. The drug should not touch the esophagus. When they touch, risk of erosive esophagitis. And newer drug like our zolinronate are given intravenous. The intravenous bisphosphonate most common problem flu-like symptom like fever, chills, rigor. But the most important adverse effect of intravenous bisphosphonate, nephrotoxicity. They may cause acute renal failure. So before and after infusion of bisphosphonate, check the renal function test. Rarely, bisphosphonate may cause adverse effect of osteonecrosis of jaw, mandible. This is important. Look here. Osteonecrosis of femur neck. Femur neck means that is an adverse effect of steroids, corticosteroids. Whereas osteonecrosis of jaw, the so-called mandible main thing of bisphosphonate. And rarely, bisphosphonate also have a risk of causing stress fracture in the lateral cortex of femoral shaft. Rare possibility. Okay. Next question. Interesting question. Image-based question. Look here. The cardiovascular response of a normal man were recorded and shown in the figure. This 15 minutes infusion of drug X. They given drug X. Following the drug X, what happened to systolic BP, diastolic BP, what happened to peripheral resistance, and what happened to heart rate, they given the picture. From the picture, you should find out which of the following drug was the most likely the given X. Okay, so following X infusion, the response occur here. So find out the drug X. Options of propranolol, isoproterenol, norepinephrine, methacholine. Here, interesting. After using drug X, there is a increase in systolic blood pressure and there's a fall in diastolic blood pressure. This is one finding. Second, there is a reduction of peripheral vascular resistance. One more thing, there's an increase in heart rates. This is a finding. Now go through your option. Propranolol. We know propranolol, a beta blocker, this will cause a reduction of heart rate. Here there's an increase in heart rate. So ruled out. Then I will come isoproterenol a little bit later, wait for some time. Methacholine, a M2, cholinergic agonist. This also causes reduction of heart rate. So this is also ruled out. So option can be either isoproterenol or norepinephrine. Look at the question. Norepinephrine acting on alpha 1, alpha 2, beta 1, but has no significant action on beta 2 receptor, norepinephrine. Now look here, since there is no significant action on beta 2, there may not be vasodilatation. There may not be reduction of peripheral resistance and there may not be fall in diastolic BP. So this also ruled out. The right answer for the question option B, isoproterenol. Now I explain how these isoproterenol are going to cause increase in systolic BP, how it going to cause fall in diastolic BP, how they going to cause reduction of peripheral resistance, increase heart rate. Everything I will discuss. Listen here. Isoprotein I'm going to discuss further. First you should know, normally we have a formula for blood pressure. Please note, the formula for BP is equal to cardiac output multiplied by peripheral resistance. In this formula, cardiac output responsible for systolic BP, whereas the peripheral resistance responsible for diastolic BP. This is a fine. So fine. Physiology. Now we are going to apply the point. For example, I want to know what happened to BP and heart rate by using isoproterenol. It is also called isoproterenol. Isoproterenol. It is also called isoprenolone. Isoprenolone normally acting on beta 1, beta 2, beta 3 and it has no significant action on alpha receptor. Now work out, since acting on beta 1, we know beta 1 receptor C in the heart. By stimulating beta 1, it will increases cardiac output. When cardiac output increase means definitely there going to be increase in systolic blood pressure. And this drug having beta 2 action. Beta 2 receptors are normally seen on peripheral blood vessels. By activating beta 2, causing vasodilatation. Definitely there will be reduction of peripheral vascular resistance. This may cause fall in diastolic blood pressure. So 3.1, the drug increases systolic BP, decreases diastolic BP and also causing reduction of peripheral resistance. Last one point, look here. Whenever there is a fall in diastolic BP, to compensate the fall, there will be reflex sympathetic activation. When reflex sympathetic activation happen means sympathetic. In the heart, we have a sympathetic called beta 1. When beta 1 activated, this may cause reflex tachycardia. So there will be increase in heart rate also going to happen. So our question solved. That means what? My drug going to cause increase in systolic BP, fall in diastolic BP and also causing reflex tachycardia. So that image is showing the effect of isoprenolone. That's the point. Okay. The next question. Which of the following antidepressant having maximum inhibitory effect on reuptake of norepinephrine than serotonin? Look here. Option given are amitriptyline, meprotylene, amoxicillin, clomipramine. Here one interesting question after all the given options are belonging to tricyclic antidepressant group. And we know the common mechanism of action of all the tricyclic antidepressants will be inhibiting reuptake of norepinephrine and serotonin. So question, in general, all the tricyclic antidepressant will common mechanism action inhibiting reuptake of both serotonin and norepinephrine. But here the question, among the given option, which drug has maximum inhibitory effect on reuptake of norepinephrine than serotonin? The answer for this question, option B, meprotilin. Why? I'll explain now. Look here. The common example for tricyclic antidepressants are we having clomipramine, doxepin, imipramine, amitriptyline, and we also have nortriptyline, desipramine, amoxapine, meprotilin, reboxetine. All these are examples for tricyclic antidepressant. Here question. The common mechanism of action of all the TCA is inhibiting reuptake of both norepinephrine and serotonin. So TCAs are non-selectively inhibiting reuptake of serotonin and norepinephrine. In this, if you look at my slide, same 1, 2, 3, 4, 5, 6, 7, 8, 9. Here I put one demarcation. This because these 5 drugs are preferably inhibiting reuptake of norepinephrine than serotonin. So these drugs also inhibiting norepinephrine reuptake and serotonin, but they preferably inhibiting maximally the reuptake of norepinephrine than serotonin. So what Goodman says, among the TCA, reboxetine has most inhibitory effect on reuptake of norepinephrine. Next comes meprotilin. So in your question, among the given option, meprotilin is the one has maximum reuptake inhibitory effect on norepinephrine than serotonin. So in ascending order, for example, clomipramine is a pure non-selective reuptake inhibitor of norepinephrine and serotonin. As in ascending order, the reuptake inhibition of norepinephrine is more. This is purely non-selective. It is minimally inhibiting reuptake serotonin, maximally norepinephrine. This again maximum norepinephrine. As advances, this highly selective norepinephrine reuptake blocker. Next, meprotilin. So just one point, these 5 drugs are preferably inhibiting reuptake of norepinephrine than serotonin. This point important. Okay, now extra points are all the TCA having some extra property. The extra property, all the tricyclic antidepressant also having antihistaminergic, anticholinergic, and minimal alpha blocking property. This is very, very, very important. Okay. Now, another interesting question. Among the TCA, we have one drug called clomipramine. The clomipramine is approved by FDA for OCD, obsessive compulsive disorder. So question, which is the tricyclic antidepressant approved for treating OCD, meaning clomipramine? But remember, normally for treating OCD, the first line drug of choice will be SSRI. This point keep in mind. Normally for treating OCD, first choice will be SSRI. Suppose the question comes, which is the tricyclic antidepressant approved by FDA for treating OCD? Mean answer clomipramine. Next question, doxepin. It's a tricyclic antidepressant having very high antihistamine action. This again important. The doxepin having very high antihistamine property, thereby useful for controlling allergy, itching in case of atopic dermatitis and lichen simplex. Next, imipramine, a wonderful drug that has very high anticholinergic property. Following, imipyramine having very high anticholinergic action, thereby causes urinary retention. Because of causing this action, imipyramine can be useful for treatment of nocturnal enuresis. But for this condition, drug choice desmopressin. Desmopressin, a V2 analog of vasopressin. So question, normally for treatment of nocturnal enuresis, drug choice desmopressin, but imipyramine can also be useful because it has anticholinergic action causing urinary retention. Next, amitriptyline, special. Amitriptyline, TCA, not only useful for treating depression, it is also useful for treatment of prophylaxis of migraine. Amitriptyline useful for prophylaxis of migraine and also useful for treating diabetic neuropathy pain. But in this area, you should know amitriptyline can be useful for neuropathy pain, but for diabetic neuropathy pain, usually the first choice will be gabapentin or pregabalin. The GABA analog, the so-called gabapentin, pregabalin, they are the best first-line choice for treatment of neuropathy pain. The last one extra point I want to tell you, look at this. We have one drug called amoxapine. Questions, look here. Amoxapine originally is a tricyclic antidepressant. The mechanism action inhibiting reuptake of norepinephrine and serotonin. But what I want to tell extra point, it is not only having antidepressant property. This drug having additionally D2 blocking property. So remember, amoxapine has additionally D2 blocking action, thereby having antipsychotic activity also. So question, which is the antidepressant has additionally antipsychotic action? Mean, think of amoxapine. And because of blocking D2, it may cause adverse effect of galactoria and EPS. So question, which is the tricyclic antidepressant causes adverse effect of EPS? Mean, think of amoxapine. Because amoxapine having the property of D2 blocking action. That's most important. Next, which one of the following serotonergic receptor is a ligand-gated receptor? Options are 5:1, 5:2, 5:3, 5:4. Remember. All serotonin receptors are G protein coupled receptor. Only one exception is there. That is called 5:3. 5:3 alone ligand-gated receptor. Okay. So answer for the question, option number C, 5:3. 5:3 alone ligand-gated. Now I will go for extra point. Look here. Actually, there are seven subtype of serotonin receptors are there. That is 5:1, 5:2, 5:3, like that up to 5:7. Total 7 subtype of serotonin receptors are there. Here, first point, all these serotonin receptors are G protein coupled receptor. Only one exception called 5:3, that's called ligand-gated receptor. Here, extra point mean, if we say a receptor G protein coupled mean, it can be either GS or GI or GQ. This and all we discuss in regular class in general pharmacology called pharmacodynamic receptor mediated mechanism action. Here what I want to say, among the serotonin receptor, 5:1 is the GI receptor, inhibitory adenyl cyclase, GI. 5:2 is the GQ receptor. 5:3 is a ligand-gated opening sodium ionic channel. Whereas 5:4, 5:5, 5:6, 5:7, the 5:4, 5, 6, 7, all these are GS receptor. So 5:2, I repeating, 5:1 mean GI receptor, 5 is 2 mean G cube, 3 mean ligand gated, remaining 4, 5, 6, 7 all GS receptor. So remember, all serotonin receptors are G protein coupled. Only one exception called 5HT3. 5HT3 alone ligand gated receptor. Next, adenosine antagonism resulting in all except. This is physiology plus pharmacology related question. Adenosine antagonism resulting in all except. Options are arrhythmia, anticonvulsion, diuresis, bronchodilation. There are two ways of answering. If you know physiology, you can answer simply. Otherwise, if you know pharmacology also, you can answer simply. For example, adenosine antagonism. For example, we have one drug called theophylline. Theophylline, one of the best example for adenosine antagonist. This drug can cause bronchodilation, useful for asthma. So, right. An adverse effect of theophylline or arrhythmia, seizure and diuresis. Seizure. That means theophylline is going to cause seizure, not anticonvulsion. So, answer is option B. So, how to go correctly mean? First, you should know physiology of adenosine. Then we go for adenosine antagonist. Listen carefully. I'll explain slowly. Look here. First, I'm going to discuss physiology of adenosine. See, actually, adenosine seen in our body in so many areas. In the brain, adenosine acting as a endogenous anti-epileptic substance. So, function of adenosine in the brain is having anti-epileptic action. I'm talking physiology. And adenosine receptor also seen on the bronchus. So, when adenosine acting on adenosine receptor in the bronchus, it causing bronchospasm, bronchoconstriction. And adenosine receptor also seen on proximal convertible. So, when adenosine acting on PCT causes sodium water reabsorption. It's a physiology. With this knowledge, go one extra point. We have something called adenosine antagonist. For example, theophylline, aminophylline. All these are methylxanthine. They call adenosine antagonist, useful for treatment of bronchial asthma. Okay. Now look at the point. Since theophylline is an adenosine antagonist, this will block the adenosine in the bronchus, causing bronchodilation. Thus, why useful for asthma. But question: when a patient taken overdose of theophylline, in overdose, theophylline going to block the adenosine action in the brain, as well as blocking adenosine action in the kidney, thereby causes adverse effect of seizure and diuresis. So it's important. Theophylline causes adverse effect of seizure and diuresis because of what mechanism? Because of blocking adenosine receptor. In overdose, theophylline blocking adenosine action in the brain causes seizure, and blocking adenosine action in the kidney causing diuresis. Okay. Next point. We have one drug called adenosine agonist called dipyridamole. This drug in olden days it was used for treatment of angina, but today we don't use because this drug causes adverse effect of coronary steal phenomena. So this is not in use. So dipyridamole, a adenosine agonist, not used nowadays because of causing adverse effect of coronary steal phenomena. Here one extra point. We have one drug called adenosine, a very short acting drug having vasodilatory action, useful in angiography to dilate the blood vessel. Okay. And last question regarding adenosine. Look here. We have adenosine as a drug. Adenosine as a drug used as a drug of choice for treatment of supraventricular tachycardia. So, we have adenosine as an injection useful for treatment of supraventricular tachycardia. Here two extra points. How this drug controlling arrhythmias. This drug stimulating acetylcholine sensitive potential. So, it's having potential opening property. Okay. Thereby increases the refractiveness of AV node. So AV node is not responding. So there's a delay in AV conduction velocity, thereby controlling tachyarrhythmia. Here, 2 to 3 point. It is given intravenously, especially given rapid bolus injection. This important question. Why adenosine given as a rapid bolus injection? Why not slow IV infusion? It has to be given only rapid because adenosine very short acting. T off is less than 10 seconds only. Because of very short acting, this drug should be given very rapid bolus. Why short acting? This is short acting because adenosine rapidly taken up by vascular endothelium. If we give injection adenosine, the adenosine rapidly taken by endothelial cells and adenosine rapidly undergo metabolism by one enzyme called adenosine deaminase. Because of rapid uptake by the endothelium and because of rapid metabolism, adenosine very short acting only for less than 10 seconds. So question 1, the most ultra short acting anti-arrhythmic agent adenosine and it's also drug of choice for treatment of acute supraventricular tachycardia. Next question. Lexipafan is a dash useful in dash. So new drug doctor. Lexipafan originally platelet activating factor antagonist useful for treatment of pancreatitis. So just to inform the point, we have lexipafan and what the apafan. Lexipafan, apafan both are platelet activating factor antagonist useful in pancreatitis. Just new point. Then surfactant analog useful for acute respiratory distress. This new point, please note. We have something called Bractan, Boractan alpha. They are called surfactant analog useful for treatment of acute respiratory distress in premature newborn baby. Serotonin antagonist useful for carcinoid. For example, we have one thing called cyproheptadine. Cyproheptadine primarily a H1 blocker, antihistamine, but also having anticholinergic action plus 5-HT2 blocking action. That is serotonergic blocking action. This can be useful for carcinoid syndrome. And NK1 antagonist useful for vomiting. This is important. We have a lot of example. For example, we have something called apripatent. Please note, we have something called apripatent, fosapripatent, rolapatent, NEETPG. All these drugs are called as NK1. NK1 means neurokinin 1 antagonist useful for treatment of anti-cancer drug therapy induced vomiting, especially useful for treatment of late phase vomiting. When you give anti-cancer drug, they may cause early phase, immediate vomiting, sometime 24 or 48 hours later. So for treating late phase vomiting due to anti-cancer drug, they use this. Because all these are having very longer duration action. So apripatent, fosapripatent, rolapatent, NEETPG or anti-emetic belonging to neurokinin 1 blocking group. Next. Cannabinoid antagonist useful for all except. This is another interesting question. Options are vomiting, tobacco dependence, drug addiction, alcoholism. Here, why this question they mean cannabinoid agonist and antagonist. Two things are there. Question: cannabinoid antagonist useful for all except. The answer for the question option A. Why A? For example, we have something called cannabinoid agonist. Look at agonist like nebulone and dronabinol. They are the one having anti-emetic action and appetite stimulating property. So cannabinoid antagonist not useful for treatment vomiting. Cannabinoid agonist are useful for treatment of vomiting. This point important. We have nebulone and dronabinol. Both are cannabinoid agonist useful for treatment of vomiting, especially useful for treatment of anti-cancer drug-induced vomiting. Here, one super important point. These drugs are not only antiemetic, they are also having appetite stimulating property, thereby causing weight gain property also. It's another important point. Okay, that's about cannabinoid agonist. Whereas cannabinoid antagonist, for example, we have something called rimonabant. Rimonabant is a cannabinoid antagonist. This antagonist useful for treatment of smoking control or drug addiction or controlling the habit of alcoholism. Look here. Rimonabant useful to control smoking habits, tobacco, useful for control drug addiction, also useful for controlling alcohol habits. That's rimonabant. But rimonabant causes adverse effect of too much of psychiatric problem. So this drug was withdrawn from market, because of causing psychiatric problem. Anyway, don't get confusion with the agonist antagonist. That's why I framed this question. Okay, I think all the 10 questions were discussed. So please read well, doctor. Each and every second is accountable. Don't waste your time. So do well. May God bless you. All the very best. Thank you.